So I'm going to try and cover both complication and surgical management in the same talk as in surgical management. And Shrikant has highlighted that it's not as simple as we think it is. They can have a chronic relentless course, and all of you have seen these patients that the allergy doesn't go away. And we keep telling them that yes, you will grow out of it. And I'm always very surprised when some parents bring back their children after a couple of years and they say that the child has been allergy-free for the past couple of years, and I'm very happy, but I'm usually very surprised. And we've seen patients where it progresses to adulthood also. And what's the burden? They can have multiple complications, as was pointed out, ranging from, as somebody asked, they have that browny or brownish color, and the major ones we have glaucoma and cataract, which are due to the steroids, we all know that. They can also have corneal scarring due to extensive kind of this vascularization down, and then also due to shield ulcers. They can have infectious keratitis and ocular surface problems, including dry eye and stem cell deficiency. So all of these that you can understand can easily lead to irreversible vision loss unless we do something. So quickly, I'm going to talk about the surgical interventions and when do we need to do it. So we need to do it for certain scenarios, for example, in the case of shield ulcer, and then, of course, cataract and glaucoma, if glaucoma is not medically managed. In patients with advanced keratoconus, we know that they have a strong association with allergy. In patients, a few of them we have seen with this problem, but limbal stem cell deficiency is luckily rarer. And of course, these patients can come with microbial keratitis. What are the surgical options for giant papillary conjunctivitis? One of the simplest and best kind of option that we can think of is a simple supratarsal steroid injection. So we have patients who come in with these giant cobblestone papillae, very active allergy. So it's like giving a pulse dose of steroids. So just like you can, in uveitis and inflammation, you give an intravenous pulse dose. So this is for the eye. So it's an ocular pulse dose of methylprednisolone or triamcinolone that you want to give into this area. But it just sort of jumpstarts or kickstarts the anti-inflammatory or anti-allergy mechanism. So I'm just coming back to that. The next thing is about simple surgical excision. Never do it. So these cobblestone papillae that look like they're causing a lot of problems, once the allergy is very inactive, the papillae will not cause a lot of problems. We will cause problems if we shave, excise it. In a very rare situation, and I'll show you an example, you can consider sort of a debriding it if there's a lot of keratin, as in this particular case, and it's causing multiple erosions on the cornea. And in that case, I would put an AMG on top of it. So don't do a shave excision of this. It'll just cause a lot of scarring and increase the allergy. So what's a technique for supratarsal injection? You can use the 26 or 27 gauge needle. Which drug should you give? So you should make sure that you're able to check the eye pressure and there isn't any steroid, the child is not a steroid responder. So you can give short acting if you're not very sure about the compliance, or you can give long acting if you're very, very sure that you're able to follow up this child and you can check the pressure. So there'll be dramatic results. In the next day itself, the child may be very, very calm and not rubbing the eye. And the thing is, you can also repeat it. So I'll hope the video plays. Okay.